certified trial. Yeah. He has, apart from his intensive care credentials, he has an MSc from the London School of Hygiene and Tropical Medicine, MSc in clinical trials, and he's associated with the George Institute of India. He established the Indian Registry of Intensive Care, and he brought in so many critical care trials to India. Just to name a few: Solidarity, Remap Caplovit, Covisteroid 2, Megarox. Lots of clinical trials going on in India because of Bharat's initiatives. And he is going to talk on transfusion triggers in traumatic brain injury. Over to you, Bharat.
Thank you. Thank you so much, Dr. Deva, for that very kind introduction. Thanks to Dr. Prashant, the Society of Neurocritical Care, for this invitation. An absolute honor and privilege to be here to share some of my insights on this particular topic. Thank you for the opportunity. I'll try and share my screen. Okay, you're able to see my screen? Yeah?
Yes.
All good?
Perfect.
Yeah. Thank you. Thank you so much. Okay. I'm going to get started. Just a second. Yeah. I'll minimize this. Okay. Slides are transitioning? Perfect. Okay. Thank you.
Yeah.
So I've been tasked with talking about transfusion thresholds in traumatic brain injury, and sort of discuss some of the recent trials, and then talk a little bit about whether I think we should change practice or not. And that's of course up for discussion at the end of the talk. No financial or intellectual conflicts of interest as far as this talk is concerned. I'm funded for 50% of my time by a grant from the Wellcome Trust in UK, and that's my email ID. So this is sort of what I'm hoping to cover in the next half an hour or so. I'll talk about why do we care about transfusion thresholds? Should we care at all in the context of traumatic brain injury? What do we know about transfusion and transfusion thresholds in critically ill patients? What do we already know, I guess? And then we will talk about a couple of the recent trials, and then try to conclude by talking about should we change practice or not. Okay, so I'll begin by talking about why should we care, or why do we care about transfusion thresholds? And this may be sort of obvious and maybe even very familiar to many of you, but essentially it all boils down to the fact that low hemoglobin or anemia can be deleterious to the injured brain. And the impact of anemia essentially depends on to what extent the autoregulation is disrupted in the brain. This particular figure is from a study that I think came out in the 90s, 97, 95, 96, 97, I think. Yeah, 97, where these researchers modeled, developed a model using animal data, which looked at the impact of low hemoglobin on various blood flow parameters, so cerebral blood flow, oxygen extraction, CMRO2, and then applied that model to some human experimental data. And what they found is that so they have the figure shows what happens in normal brain, which is the bold line, and then the ischemic penumbra, which is the non-bolded line here. So what they're showing is what is the impact of different hemoglobin levels on CBF, oxygen extraction, and CMRO2. And what you will see is that in a normal brain, as the hemoglobin drops, which is the topmost figure here, the cerebral blood flow increases, right? It increases to compensate for the decrease in hemoglobin. This phenomenon happens, the model that they've taken is a model of, sorry, I forgot to mention this, the model they've taken here is of a stroke, sort of a situation with the ischemic penumbra is what they've taken as the reference injury. But what they're trying to show here is that in ischemic penumbra 2, the cerebral blood flow does go up with drops in hemoglobin, but you're starting as such at a low CBF, and then the increase in CBF is obviously much, much lower as compared to what a normal brain has. And then when they looked at oxygen extraction, now oxygen extraction again, so in a healthy brain, oxygen extraction to start with is low, is sort of lowish, preserved. But as the hemoglobin drops, oxygen extraction goes up in the normal brain. In the ischemic penumbra, oxygen extraction is already high to begin with. And as the hemoglobin goes down, it does go up. But the problem is that since you're already operating at such a high oxygen extraction, the amount of increase that can happen is actually very, very low. So CBF increase happens, but is much, much lower than the normal brain. In the ischemic penumbra, oxygen extraction is already high. Therefore, the margin by which it can increase is very, very low as compared to normal brain, where oxygen extraction is at a relatively low level and there's substantial room for it to increase in the face of anemia. And then, of course, the most important thing is that in the normal brain, the CMRO2 is reasonably maintained at even hemoglobin levels of 7 or 6, whereas that's not the case as hemoglobin drops in the injured brain, and you'll see a steep decline in the cerebral metabolic rate of oxygen uptake, right? So that CMRO2 drop is pretty it's actually quite steep in the injured brain. The next figure that you're seeing also illustrates the same concept from a different paper, which again shows the panel on the left shows you how in a normal brain, as anemia, as the hemoglobin drops, the blood vessel diameter increases, the cerebral blood flow increases, and the DO2 is maintained until the hemoglobin drops to, say 7 or 6 grams per deciliter. And that's when the DO2 starts dropping. You contrast it to the injured brain, where yes, the dilatation happens, where CBF increases, but you're starting off with a relatively lower DO2, and it starts to drop precipitously at a hemoglobin level of, say, 9 or 10 grams per deciliter, in contrast to the normal brain, where it's maybe at 6 or 7 grams per deciliter. So again, illustrating the point that in an injured brain, the impact of a low hemoglobin is substantially different and more, obviously more deleterious than what would happen in the context of a normal brain. This is a paper from 2007 where these investigators took data from a series of TBI trials and looked at the prognostic value of different admission laboratory parameters. They looked at lots of things, hemoglobin being one of them, but they also looked at sodium, glucose, pH, and so on. I'm going to focus only on the hemoglobin, and that's sort of what I've highlighted. And again, this figure illustrates that in a cohort, in a nested cohort, using randomized control trial data, when they looked at what are the predictors of a poor outcome, a low hemoglobin was associated consistently with poor neurological outcome. And here we're not talking about mortality, we're talking about the Glasgow outcome scale. And the lower the hemoglobin, the higher the probability of having an unfavorable GOS. And the curves or lines are essentially talking about different poor grade GOSs. So GOS 1 to 4, all of them are substantially higher when the hemoglobin is low, right? So you have experimental model data, you have some animal data, you have human data, all of it seems to suggest that there is an association between low hemoglobin and neurological outcomes, and there's also obviously the physiological rationale. Another paper which associates or which talks about this hemoglobin concentration and mortality, and also showing the point that when the hemoglobin is less than 9 grams, the relative risk, adjusted relative risk for a poor outcome is 3.1. Right. So this is looking at mortality as the primary endpoint, and the previous one was looking at Glasgow outcome scale, but illustrates the point that a low hemoglobin in brain injury is not good, right? It's associated with poor outcomes. So if we know all of this, right, if we know that low hemoglobin is physiologically deleterious, if we know that low hemoglobin is associated with poor neurological outcomes as well as mortality, doesn't it therefore make sense that we should just correct the hemoglobin values? We should just correct the anemia. I think whenever you're making such decisions or when you're thinking about that, you obviously consider one, does the physiology translate into actually therapeutic effectiveness? Meaning, does correcting a lab value actually improve the outcome? So that's a question that you need to ask. And second, does correcting a value have downsides, right? I think the downsides of transfusing are well known to, I think, this audience. I won't get into all of the complications that you can have. There are infectious complications to transfusion. There are non-infectious complications. So the downsides are clear. So that then brings to the question of, does transfusing improve outcomes, right? Does correcting the lab value actually improve outcomes to a point where it outweighs the risks associated with transfusion, right? So that's actually the rationale that we are looking for. So before we get into whether transfusions are effective in the brain injured cohort, let's look at what we in general know about transfusion in the general critically ill patient cohort. This is, of course, the well-known TRIP trial from 1999, where investigators compared a transfusion strategy or thresholds between 7 grams and 10 grams per deciliter. Restrictive was 7 and liberal was 10. And their overall outcome was not different between the two groups. In two specific subgroups, where patients had an Apache score of less than 20, restrictive appeared to be better, and in younger patients, again, restrictive appeared to be better. The conclusion of this trial was that restrictive is not inferior, it's not different. I shouldn't use the word inferior. It's not different to liberal and is perhaps superior in certain populations. The problem with TRIC, though, was that only 5% of the trial cohort had a neurological diagnosis. So very few patients with a neurological diagnosis. This is a systematic Cochrane systematic review, which pooled data from 48 trials that compared different transfusion thresholds across a variety of settings. Not all of them are ICU trials, but nevertheless, when they pooled all of this data, again, no difference between lower and higher thresholds. You can see that the pooled estimate is right on the line of no difference. The review, in fact, concluded, interestingly, by saying that more research is needed to establish the blood count at which transfusion is needed in certain specific populations, right? So they spoke about people that have suffered a heart attack, people that have brain injury or have cancer as groups where further research is actually required. So this is sort of what we know in the context of the general critically ill population. So coming to brain injury, one of the earliest trials that looked at this question was from 2014. This is an interesting factorial trial that compared two sets of interventions. It compared the effect of erythropoietin versus placebo on neurological outcomes. It also compared two hemoglobin thresholds, 10 transfusion thresholds, 10 gram and 7 gram, again looking at neurological recovery. The population they enrolled were patients with closed hand injury who were unable to follow commands following resuscitation and enrolled within 6 hours of injury, so enrolled pretty quickly or pretty early. The intervention was a transfusion threshold of 10 grams. The control was 7 grams, and they looked at Glasgow outcome scale at 6 months. They also looked at survival. And the trial actually did not show, and their hypothesis was that liberal would be better, and the trial did not show that. The survival curves sort of really did not separate out. If anything, the liberal group had a higher proportion of adverse events. But what is important to note is that this is a very small trial, about 200 patients or so, and it's very hard to draw definitive conclusions from this trial. But at least their data suggested that there was no difference, and if anything, perhaps there was more adverse events in the liberal threshold, specifically thromboembolic events. So this is sort of what we have known thus far, right? So we know that physiologically anemia can be deleterious. There's observational data that suggests that low hemoglobin is associated with bad outcomes. We know that there are downsides to transfusion. We have looked at transfusion data in the context of the general critically ill population, where restrictive seems to be, no different to liberal. And then we had that one particular trial in 2014. Now, in the background of all of this, we've recently had two important trials, and that's sort of where I'm going to spend some of or a large portion of time today looking at those two trials in detail. The first trial is called the HEMOTION trial. This is a trial that compared liberal or restrictive transfusion strategy in patients with traumatic brain injury. So the research question that they were asking is, among critically ill adult patients with moderate or severe TBI, is a liberal strategy of red cell transfusion associated with better patient-centered outcomes? And their hypothesis explicitly was that liberal would be better, right? So the PCOS for this particular trial, the patients they included were those that were over or equal to the age of 18 years, admitted to an ICU with moderate to severe TBI, GCS between 3 to 12, and having anemia, right? So hemoglobin of less than 10 gram per deciliter at the time of randomization. Inclusion, they had to have, they should be less than 24 hours between injury and the first visit to ER. So that was part of their inclusion criteria. And the patients had to have moderate or severe blunt TBI, not penetrating injuries. They excluded those that did not have a fixed address, those that had received any transfusions after coming to the ICU and before randomization, those that had some sort of objections to transfusions, like Jehovah's Witnesses, any other contraindications to transfusions. If the GCS was 3 at the time of randomization or prior to randomization with bilateral fixed dilated pupils, if the patients met a brain-based definition of death, if there's active life-threatening bleeding, and if there's any decision to withhold or withdraw life support. All reasonable exclusion criteria in my view. So this is sort of the population that they enrolled. In the liberal group, transfusion would be triggered by a threshold hemoglobin of less than 10 gram per deciliter. In the comparator control arm restrictive group, transfusion would be triggered by a threshold hemoglobin of less than 7 grams per deciliter. It's important to note that the red cells in this trial were all leuko-reduced, and the goal was to transfuse within 3 hours from the time a patient achieved the threshold hemoglobin. So as soon as possible and within 3 hours. Their primary outcome was an unfavorable outcome on the extended Glasgow outcome scale. They used an approach called sliding dichotomy, and we'll talk about that at 6 months. So they looked at a longer term neurological outcome as the primary outcome. So for those of you that may not be familiar, this is the Glasgow outcome scale and then the Glasgow outcome scale extended. So GAUS goes up to 1 to 5, which is the outcome that the 2014 trial had used. This is GAUS-E, which has further sort of qualifications of the various outcome states. And it goes from dead to something called upper good recovery. And it's sort of self-explanatory. There's obviously, if you have a GOS of 5 and below or 4 and below, you would be considered to have a poor outcome. And 6, 7, and 8 are all considered as good outcomes, even 5 perhaps. But 4 and below, certainly a bad outcome. We'll talk a little bit about how they looked at their outcome and this idea of a sliding dichotomy. So as I said, the primary outcome was an unfavorable GOSE using a sliding dichotomy approach. What does this mean? So what they did is they did something interesting. Every patient at the time of randomization or at the baseline was categorized using a prognostic model called a TBI impact prognostic model. And we look at what variables are there in that model. But they used this model to first prognosticate patients as having a worst prognosis, an intermediate prognosis, or a best prognosis, right? So they wanted to give some sort of a starting, status of where the patients would be, or at least where they thought they might be using the model. Now, if you're a patient that fell in the worst category, what would be a bad outcome for that patient would be if they ended up at 6 months with a GAUS-E less than 3. If they were in the intermediate category, they would be considered to have an unfavorable outcome if their GAUS-E was less than 4 at the end of 6 months. And if they started in the best prognostic category, they would be considered to have a poor outcome if the GAUS-E was less than 5. So I think this is interesting because they didn't want to say anybody below 5 or 4 is bad. They wanted to give some context to what a bad outcome is. So they prognosticate what they anticipate each patient's outcome is going to be. And then they, of course, when they look at the GAUS-E at the end of 6 months, each patient's, they compare that to each patient's original state or original expected state, and then they're categorized as having a favorable or unfavorable outcome. Now, whether this approach is something that resonates with all of us, whether it's acceptable, is all up for discussion. But they try to have some sort of a baseline prognosis or prognostication of what each patient's outcome was likely to be, and then they looked at the outcome in the context of that prediction, right? There were a number of secondary and tertiary outcomes, mortality. They used a number of quality measures, functional independence measure, EuroQoL, which is the European Quality of Life Scoring, VAS, and the EQ5D file. They had a quality of life after brain injury scale. So for FIM, EuroQoL, VAS, and quality of life after brain injury, the higher you are, the better you are. For patient health questionnaire, which looks at depression, the higher you are, the worse you are. They also had tertiary outcomes, number of red cells transfused, the lowest daily hemoglobin level, complications related to transfusion, mechanical ventilation duration, length of stay, and so on. Okay. Continuing with the methods, the trial was conducted in 34 centers in Canada, UK, France, and Brazil. There was an independent data safety monitoring board, which reviewed the trial data after every 25% increment in the sample size. And there was a formal interim analysis at 50% sample size. The interim analysis did ask them to continue the trial, so there were no red flags at that stage. Obviously, the trial was undertaken after obtaining written informed consent from surrogate decision makers. And then, of course, if the patient regained capacity, they would also take consent from the patient. The protocol was registered on clinicaltrials.gov, and they had a statistical analysis plan much ahead of opening the database. This was a prospective randomized open-blinded endpoint trial design. They call it a probe trial design, which makes it sound fancy, but essentially it's just a parallel group RCT, which is open label, meaning there's no blinding except for those that are assessing the outcome, right? And it does make sense. It's hard to blind this kind of a trial. The randomization was a central computer-generated standard methods, concealed allocation, 1:1. They used variable permuted blocks of sizes 4 and 6. They stratified by center, all pretty standard. The intervention, whether you're a liberal or restrictive group, was applied until ICU discharge. All other care other than the intervention was left to the discretion of the clinician. They encouraged the use of Brain Trauma Foundation guidelines. So for sample size, they made some assumptions. They took an alpha of 0.05, a beta of 0.20, which gives them 80% power. They assumed that the control group would have a poor outcome rate of 40%. And they also assumed that a liberal transfusion threshold would make this better by 10%. So the liberal group would have an unfavorable outcome of 30%, and the control group would have an unfavorable outcome of 40%. They accounted for some loss to follow-up, and eventually they arrived at a sample size of 742 patients. One can obviously ask the question whether we think just the strategy of liberal transfusion would improve the outcome by 10%, and that's, of course, a question for discussion. The analysis used the intention to treat principle. There was no adjustment for all the multiple tests that they undertook, which is called as multiplicity. The primary outcome analysis, as we discussed, used a sliding dichotomy approach. They were pre-specified sensitivity analysis for completed case per protocol, best worst case scenarios, and a number of things. Secondary outcomes analyzed after adjusting for center and for the TBI impact model, and a p-value less than 0.05 was considered significant. For those of you that may not be very familiar with statistics, I can assure you that these methods were all pretty reasonable, pretty robust. And I don't think there were any red flags with the strategy that they used, except for whether we think the sliding dichotomy is the right approach. But within the analysis itself, I don't think there were any questions. So they start with 6,184 patients that they assess for eligibility. A large proportion, more than half, get excluded because they don't meet the inclusion criteria. And then 2,865 meet inclusion criteria, but there are still that many that get excluded because at the next level of screening, there were again some more exclusion criteria that they found. And then there were 700 odd patients that were eligible but not enrolled because in a large group, 276 consent was declined by the patient or the surrogate family member. And in 114, physician believed that the trial was not in the best interest of the patient. Some of it was, of course, logistic things such as not having research capacity, patient coming in the night, etc. But it does show you that, to enroll 740 patients, they had to screen almost, 10 times that sort of a number. So they randomized 742 patients, 371 to liberal arm, 371 to the restrictive arm. And then again, there were a few withdrawals for lack of consent or withdrawal of consent, a few missing outcomes, but I didn't see any red flags. Unfortunately, these are going to happen in a trial of this scale with an outcome at 6 months. But at the end, you have 364 in the primary analysis on the liberal arm and 358 in the restrictive arm. So that's sort of how the flow of trial participants was. Looking at the demographics of the patients, so what to me, most of the baseline characteristics I think are well balanced, but a few things that I want to point out: very few female patients, right? Only a quarter of the patients, under 30% of patients were female in the entire trial. To me, what was also interesting is that the primary mechanism of injury is actually a category called other, which I suspect is false, perhaps, which is almost 50%. And motor vehicle collisions, vehicle pedestrian collisions are all only 20%. The total is only 20%. I thought that was interesting, but it'd be interesting to see what others say. And then this is the TBI impact prognostic model. And you can see what are the variables that go into it. They look at the severity of brain injury. They look at the GCS score, motor score. They look at pupil reactivity, hypotension, hypoxemia, the CT classification, and so on. 50% of the patients are Marshall classification 2 in both the arms. So no major imbalance there. So these are some important characteristics. Again, a few other things that I want to point out. Monitoring of intracranial pressure happened in 56% as compared to 63%. In the liberal arm, 56 versus 63 in the restrictive arm. I don't know if this influenced results. Does it suggest that the liberal arm had less sicker patients, or does it suggest that they did not have access to intracranial pressure monitoring? That's not clear to me, because when you look at decompressive craniectomy, more patients in the liberal arm had a decompressive craniectomy. So what does that tell you? Does it tell you that they were sicker, or did they think that they were more salvageable, right? So there is some imbalances here that we have to consider. Similarly, surgery for progressive hemorrhage more in the liberal arm than the conservative arm, in the restrictive arm. More episodes of intracranial hypertension in the liberal arm. So this goes against what we might have thought. Here it seems like sicker patients, or at least more episodes of intracranial hypertension in the liberal arm. So basically, there are some imbalances, right? There are imbalances in intracranial hypertension, in episodes of hypoperfusion, in episodes of brain tissue hypoxia, which are all more in the liberal arm, right? So how do we interpret these imbalances is something that's up for discussion, and whether they influence the results. So some baseline characteristics in favor of liberal strategy, perhaps, and some in favor of the restrictive strategy. Randomization happened within 55 hours in both the groups from the time of injury. So pretty, I would say, reasonably quick to get them into the trial. Did the arms get separated out? They did. This is the lowest hemoglobin on a daily basis for the first 28 days. So you can see a clear separation. In the restrictive arm, hemoglobin perhaps sitting around 7.5 or 8. And then here is, of course, 9.5 to 10. And sort of there's a clear separation between the trial arms. Okay, now coming to the outcomes. So the primary outcome, which I said is the unfavorable outcome on GaussE at 6 months using a sliding dichotomy approach. So overall, 68.4% of the liberal arm had a poor outcome as compared to 73.5% in the restrictive arm. So there is a 5% difference between the two arms, with the liberal arm doing better, but this did not achieve statistical significance. I also want you to remember that this is much higher than what their assumptions were. Their assumptions thought that about 40% would have an unfavorable outcome in the restrictive arm. But obviously, this is much, much higher, right? So they did get the assumptions wrong, either because of the sicker cohort or the data that they used to make those assumptions was flawed. If you take any of the different categories of worst, intermediate, and best, again, the liberal arm did better, but none of this was statistically significant. If you dichotomized as just less than 4, more than 4, again, the liberal arm does better, again, not achieving statistical significance. And of course, there are multiple tests being undertaken, and they have not adjusted for multiplicity. If you take the functional independence measure, liberal arm does better overall, slightly better again. If you take the Eurocall, VAS, liberal arm does better. If you take the EQ5D5L, liberal arm does better. On the QLibri scale, which is the brain quality of life scale, again, liberal arm does better. But remember that multiple tests are being undertaken; they're not adjusted for multiplicity, and these are all secondary outcomes. So we should always take it with a pinch of salt. If you take the depression score, the liberal arm, had a lower score, a median score of 7 as compared to 8. The PHQ-9, and then scores more than 10 were higher in the restrictive arm. In PHQ-9, we said that higher is bad, right? So that's sort of the key outcomes. And then if you look at tertiary outcomes, no major difference in complications. If you look at infections, pneumonia, etc., there's less bacteremia and sepsis or septic shock in the liberal arm. But again, I don't think we can read too much into these things. There are multiple analyses being done. Transfusion reactions, 1.6% versus 0.7%. So, slightly higher, but again, if you look at the confidence interval, it's pretty wide, right? No major subgroup differences across different subgroups, age, sex, severity of brain injury, and so on. Okay. So this is the ordinal scale that shows the outcomes on the left side. And what you're seeing is that in each of the good category outcomes or good groups, the 8, 7, 6, and 5, higher proportion of patients in liberal arm have a better outcome than, in the restrictive arm. Even if it did not achieve statistical significance, no difference in the mortality on the Kaplan-Meier survival curve. Other adverse events, the only thing to point out is that there is a higher percentage of patients that develop ARDS, 3.3 versus 0.8. And then we'll talk about this a little bit more later. I want to just take a bit of a method segue just to highlight a point about, clinical versus statistical significance. And I want to borrow information from a trial that I was part of. So we saw how, the liberal arm across a range of outcomes seems to be doing better, but it's not hitting that magic statistical significance, right? So the question comes, should we just go by statistical significance or should we look at clinical significance? This is a trial which compared 2 doses of steroids in patients with COVID and severe hypoxemia. The primary analysis was a frequent test analysis on an outcome called, number of days alive without life support. And the 12 milligram arm had higher number of days without life support, so was doing better, but did not achieve statistical significance. The p-value was 0.07. Now, do we dismiss these results or should we think a little bit more? So in the same trial, we had undertaken a Bayesian analysis as well. And what you will see immediately is that for the same outcome, you start getting probabilities, right? So the probability of benefit for the higher dose of dexamethasone was estimated to be 94%, whereas the frequent test approach could not give you this kind of information, right? It just tells you p-value, and then you have to accept it as not being important or not being significant. Whereas the Bayesian model starts giving you more meaningful information that as a clinician you can use. The probability that higher dose steroids was having any benefit was 94%. We also provided probability of harm, which was lower, right? Which is pretty low. So the probability of harm, I don't think we've shown it here, but essentially the probability of harm, if you take mortality as an example, is actually just 5.2%, right? So we can't give these kind of nuanced interpretations when you do a frequent test approach alone. And I wanted to make the segue to sort of highlight the point that there is always this issue of clinical versus statistical significance, and Bayesian analysis sometimes helps you to better quantify and give you probabilities. So that was just a brief segue to highlight that methodological aspect of clinical versus statistical significance. Anyway, coming back to this trial, my interpretation is that, based on the data that we've seen, a liberal strategy of transfusion is associated with a lower risk of unfavorable outcome, although not achieving statistical significance, but you should consider clinical significance. A liberal strategy appears to improve functional outcomes and QOL outcomes. Overall adverse events are not higher in the liberal arm, more ARDS events, but the total number of events are small. So that brings into question what is the significance of that. We do have the question whether imbalances in some of the baseline characteristics affected results. We do have a question about sample size and power, right? Did they enroll enough patients? Were their assumptions optimistic, too optimistic, perhaps, right? Okay, so we will come back to these issues. I want to take you to the next trial. So we're going to move on to the second trial that we are considering today. This is called the TRAIN trial, which is published in JAMA in 2024, end of 2024. Their research question was, among patients that were admitted with acute brain injury, not just TBI, to the ICU, what is the impact on neurological outcome of using different hemoglobin thresholds? They did not give an explicit hypothesis on the paper as to whether one is better than the other, but they asked what is the impact of different thresholds. The PCOS here is all adult patients admitted to the ICU with TBI, SAH, or intracerebral hemorrhage, and within 10 days following their initial injury. So they gave more time to enroll the patients. So within 10 days, the inclusion criteria was a GCS of less than 13 on randomization, expected ICU stay of more than 72 hours, a hemoglobin less than 9 at the time of enrollment. They excluded other neurological diagnoses such as ischemic stroke or post-anoxic coma, status epilepticus, CNS infections, known previous neurological disease, ICH due to an AVM or a brain tumor, inability or reduced ability to receive blood products, which includes, people's beliefs, pregnancy, active bleeding that's going on. Again, GCS of 3 with both pupils dilated and fixed. If there are DNA orders, any previous alloimmunization. So all standard sort of exclusion criteria as far as I am concerned. The liberal strategy here had a transfusion threshold triggered by hemoglobin of less than 9. Restrictive strategy had a transfusion threshold triggered by hemoglobin of less than 7. The allocated strategy was maintained for 28 days from the time of randomization. All other decisions were left to the clinician. But in contrast to the prior trial, which said within 3 hours you need to transfuse, there was no mandatory time period in this particular trial. The outcome was an unfavorable neurological outcome, same Gauss-E at 6 months. But here, no sliding dichotomy. They just dichotomize as unfavorable between 1 to 5 and favorable between 6 to 8. This was conducted across 72 ICUs in 22 countries. Standard randomization techniques. They're stratified by center, by type of brain injury, by GCS at the time of randomization. And patients and family members were blinded. The outcome assessors were blinded, but clinicians were not blinded. Number of secondary outcomes, I won't get into all of them, but survival, organ failure, ordinal assessment of Gauss-E scores, and so on. So their sample size assumptions, alpha of 0.05, beta of 10%, so they're aiming for a 90% power. So their initial assumptions were that the mortality is about 15% and poor neurological rates of 35%. So put together, they said in the control arm, they expect unfavorable outcome to be 50%. And they hypothesized that the liberal arm would improve this by 5% to 45%, right? So they're expecting that the benefit would be lower. And this gave them a sample size of 2,095 patients in each arm. Obviously, within some time, very quickly, they realized that they're not going to be able to enroll to that sample size. COVID also came along. There were 2 reductions in sample size because of slow enrollment. And they first said they changed their assumption from an improvement of 5% to 10%, like the previous trial. Then they further went to increase and they said we expected to increase by 11%, improve by 11%. All this brought the sample size down to 794. Obviously, any sort of sample size change in the middle of a trial, raises some questions. But presumably in this trial, the changes happened independent of them knowing the results, right? They did not know what was happening to the patients. They only changed the sample size because they were not able to enroll and they changed their assumptions. And sample size, is always a trade-off between how much money you have, how much time you have, what is feasible and so on. Okay. Their analysis, again, an ITT approach. They had a single interim analysis after enrolling 300 patients. And at that point, the DSMB told them to continue the trial. Primary outcome was analyzed using the chi-square test. Then there was an adjusted analysis, which adjusted for stratification variables. Again, they had some sensitivity analysis using multiple imputation approaches and best and worst case scenarios. Secondary outcomes, they used the appropriate tests. They had a number of subgroups, and we will look at some of those results. But again, to reassure you, fairly standard approach. I don't think there were any major red flags as far as the analysis was concerned. Flow of participants, they start with 8,200 patients. A vast majority of patients are excluded because they meet exclusion criteria. And only 88 presumably decline consent. 850 get randomized. They have a fair amount of patients that they lose. 11 withdraw consent in the liberal arm, 19 in the restrictive arm. They lose some to follow up, 4 here, 10 here, and they end up with 393 in the liberal arm and 413 in the restrictive arm. Coming to the baseline characteristics, a higher proportion of female patients here. Remember that in the previous trial, they were only less than 30%. Here it's 45%, 46%, 45 and 46%. Time from admission to randomization, the median number of days is 3 days in both the arms. Traumatic brain injury constituted 60% of the trial population overall, 60.5 and 58.2 in the liberal and restrictive arm. Intracranial pressure monitoring done in 70% in both the groups. I'm only pointing out certain characteristics. Rest of it were reasonably balanced. The initial GCS score, median GCS score of 7 and 8. At randomization, GCS score median was 6 and 6 in both the groups. The median hemoglobin at the time of randomization was 8.5 in both the groups. So maybe a couple of points that are different between the two groups, but broadly balanced groups that you see. Salvage therapy for intracranial pressure. In the liberal strategy, less patients got salvage therapies. Does this suggest that they were better off? They were worse off? I don't know, probably better off. 27% versus 31%. Did this influence the results? That's a question that will come up. less kidney replacement therapy in the liberal arm, less anti-epileptic therapy as well as the liberal arm. The groups achieved separation, yes, but the separation is obviously lower or smaller, but also because the transfusion thresholds are different here, right? It's 7 versus 9 instead of 7 versus 10. This is the median daily lowest hemoglobin up to 28 days. So there is a separation, but perhaps not as pronounced as the previous trial, which is not surprising. Okay, coming to the primary outcome, unfavorable neurological outcome dichotomized, 62% in the liberal arm, 72% in the restrictive arm, a 10% difference, which here was statistically significant. The confidence interval goes from minus 16.5 to minus 3.6. 28-day mortality was lower, but organ failure was higher in the liberal arm. ARDS in this trial, because we saw a higher ARDS in the previous trial, 7.3 versus 8.5. And of course, none of these are statistically significant. I'm just highlighting some of them. Again, they've not adjusted for multiplicity. They're doing a number of tests, none of which are statistically significant, right? But there are some differences in some of these things. Subgroups, no major subgroup effect. All of the results seem to favor the liberal strategy broadly, whether you take age groups, whether you take the different types of brain injury, the GCS at randomization. So whatever approach you take, for the most part, liberal seems to be doing better than the restrictive. The ordinal plot also shows the same thing, right? Better outcome in the liberal arm. So what is the interpretation of this trial? When you consider a more heterogeneous population of brain injured patients, a strategy of liberal transfusion threshold was associated with more favorable neurological outcome. 60% of the patients in this trial were TBI, and in this subgroup of TBI also the results are similar to the overall results. As I said, multiplicity is a problem. In general, this trial is a little bit less robust than Turgeon, the previous trial. Multiple changes in sample size. There was no mandate to transfuse within a certain time period. The trial could enroll up to 10 days from injury, so obviously a little bit further out from the time of actual injury. So I would say methodologically less rigorous than the HeMotion trial. Trial comparison. So the HeMotion trial was a parallel group international RCT open with blinded outcome assessment. Same here in the TRAIN trial. HeMotion in TBI alone, whereas here we had TBI, SAH, and ICH. Compared 10 versus 7, compared 9 versus 7. Same outcome, just that there's a sliding dichotomy versus not. Transfusion within 3 hours, no specification of interval. Sample size assumption, 10% benefit. Here initially more conservative 5% and then changed. Here in the HeMotion, liberal appears to be better, not statistically significant. In the TRAIN trial, liberal clearly better. Okay. Now that we know all of this information, right from physiological rationale to previous trial data to the recent trials, should we change practice? Now, on a philosophical note or on a broader note, whenever you decide to change practice, what are the things that you need to think about, right? You need to think about the effectiveness of the intervention. And for that, you consider the physiological rationale. You look at the totality of the evidence. You think about the average treatment effect in the trial versus the treatment effect that the patient that you have in front of you is likely to have. You think about safety. You think about cost. You think about logistics. Do you have a blood bank? Can you get blood? So many things that factor in, right? And there may be other factors that become locally relevant. So this is sort of this is a framework that you need to have when you think about, should I change my practice, right? So this is a whole bunch of things that we consider when we think about that. Now, I want to talk a little bit about totality of evidence. I put this meta-analysis together myself. So it's obviously, I didn't do an exhaustive literature search, etc. I just stubbed the data from these 2 trials. I used a free software called meta-analysis online. And when I pulled the data, so the forest plot on the left side pulls the data just as it is. As in, I took all of the data. I didn't separate it out as TBI versus no TBI. I just combined the 2 trial data, and you can see that clearly there is an important benefit to a liberal arm. Liberal arm reduces the chance of an unfavorable neurological outcome by 11% if you take a hazard on odd, and the confidence interval is 0.83 to 0.95. Now, when you come to the right side, I took only the TBI group from the TRAIN trial, and then I clubbed that data with the HeMotion trial. And again, what you see is that a clear benefit to the liberal arm, right? The risk ratio is 0.91, a 9% improvement, and the confidence interval goes from 0.84 to 0.98. Okay. I also went one step further. I decided to take some of the 2014 small trial, the 200 patient trial that we spoke about. I added that to the mix. And then when I did that, of course, the results become no longer significant. There is still a benefit 0.95, but it crosses the confidence interval. But it's questionable whether I should add the trial or not. It's a smaller trial, different era, right? 2014 as compared to 2025, 24 at least. But I wanted, in the interest of full disclosure, I wanted to show that forest plot as well. I also pulled the ARDS risk because the Hemotion trial showed that there was a higher ARDS risk. I took all the three trials and put the ARDS data together, and you see that there's no difference between ARDS and the liberal arm and restrictive arm, which sort of gives me some reassurance. Okay, so given the totality of the evidence and the forest plots that you have seen, I actually would argue that we should move to a more liberal threshold. To me, it's unclear how liberal one must be. Should it be 9? Should it be 8.5? Should it be 10? But I certainly would move away from accepting 7 grams per deciliter for patients with TBI. We should continue to certainly look at safety, resource utilization, and so on and so forth. But in my view, a 7-gram trigger is no longer acceptable in the light of this data in patients with TBI. That's my approach. This is from an old paper that suggests that apart from obviously the RCT data, you should also look at the individual patient's neurological exam. This figure does not consider the recent trial data. This is from way back from 2016 or 17, but essentially says you should factor in the neurological examination and whether there are any other systemic triggers and neurological triggers to make a decision about whether you transfuse or not. But as I said, to me, based on where the evidence stands, I would certainly think that a 7-gram is no longer acceptable, and we should certainly move to a higher threshold. What that higher number should be is obviously up for discussion. I'm going to stop there, and obviously questions, criticism, feedback, all of that is welcome. I'll hand it back to Deva, thank you.
Thank you, Bharat. That was really fantastic. So thank you for talking us through the background, the physiological rationale behind why we want to transfuse patients with brain injury, going through some of the older trials, and also analyzing the 2 trials that were published more recently in depth. And also comparing them, adding your own meta-analysis, and giving us your thoughts on what we should do. So clearly, it appears that liberal is the winner, but we don't know the magic number. What should we target for? But certainly, we should not be targeting 7 grams like we do for the general critical care. Just a few of the things that I thought were quite interesting. So in the Hemotion trial. Clearly, if you look at the liberal arm, the number of ICP events were higher. The cerebral hypoxia events were higher. But the primary outcome, I shouldn't say mortality, GOSE, was the primary outcome measure. So GOSE was lower. That's quite interesting. So if your patient is having higher ICP events, higher hypoxia events, you would expect them not to fare as well as patients that don't have such events. But that's something that I thought was very interesting. So clearly goes to show that what happens during the course of illness does not always reflect, just like how we see in ARDS. Oxygenation is never related to the outcome in ARDS. Something similar, like what happens during the course of the illness, does not reflect the outcome measure. That was one thing that I wanted to mention. The second thing about the second JAMA trial, I thought it was more pragmatic. I don't know. I want your view on that because. Our experience is, whenever we have severe TBI or some moderate TBIs, they stay on for longer, for like 40 days, 70 days. We even had patients for 110 days, etc. So when do you decide, this transfusion threshold chasing should stop? When do you move them from, hey, this is a neuro critical care patient to now the neuro part is done and I'm moving out to general critical care and my threshold is changing? Or is there something like that? What is your thought on that?
Thanks, Rima. So I certainly agree with you that the JAMA trial is more pragmatic in every way, right? In the way they included patients, they gave a lot of freedom to how the site should manage the patient, etc. So I think there are two trials. So obviously the HeMotion trial is more on the explanatory end of things, and TRAIN is more on the pragmatic end of things. But the pragmatism to me does reduce the robustness of the trial itself. To answer your point of how long should one chase the transfusion, it's a good question. I don't know I don't know the right answer. In both the trials, they ask them to maintain it until at least 28 days. I think the impact of a low hemoglobin is obviously going to be highest in the acute phase, right? I mean, physiologically, we would think, and whether that acute phase is 5 days, 7 days, 10 days, I don't know. But I think it's clearly in the acute phase, and perhaps not as relevant, post tracheostomy and maybe perhaps at a point where infections and other things are what they're dealing with. But certainly, I guess in the first, whatever we agree as the acute phase, it perhaps matters the most. But I don't know the correct answer.
So I mean, so we agree that it's not only for TBI, but also we can include ICHs and Sabarax based on the second trial, don't we?
Well, I think there's another trial that I didn't get into. I think you all are familiar with what's called the Sahara trial, which I think looked at SAH specifically, which I haven't gone into depth, but didn't seem to show a difference between liberal and restrictive, and perhaps is worth discussing in a subsequent journal club of yours. I focused on TBI, and certainly for TBI and ICH, I guess we can reasonably confidently say with TBI, I would say more confidence because more trial data. I was able to pull more information. But ICH and SIH, given that the only total SIH plus ICH is 40% of TRAIN, I don't know if I can say that as confidently, but that's also up for discussion.
Agreed. Are there any questions from the audience? We look at the chat box. Anything in the chat? Oh yeah, there are a couple of questions in the chat. Do we have any number to treat mentioned in the liberal strategy group?
We don't have, but
yeah,
but it should be fairly easy to calculate, right? I mean, we have the absolute differences. So 1 over the absolute risk reduction is the number needed to treat. So something that you can calculate yourself. Yeah.
Second one is also in the baseline characteristics, there was less TBI patients related to trauma.
So as I pointed out, in fact, I made the point that the mechanism of injury, if you motor vehicle accident, the rest are all, I think it is in the other category, which I suspect is fall. I'm not sure what it is. Assault also was not the highest group. So I guess there is that, but I don't know what the implication of that is.
Any other questions from any of the audience? You can unmute and ask, or you can type in the chat box as well. Okay, so if adopting, one more question, if adopting a more liberal strategy, what would be the target HP to strive for, or would that be individualized?
Yeah, I ended on that note saying I don't know what the correct threshold is. Certainly it's not 7. I think I would transfuse to maybe 9 at least would be my practice. If you want to individualize, the last figure that I showed or the penultimate figure I showed maybe a guide because it factors in neuro monitoring, multimodal neural monitoring, right? It looks at brain oxygen, it looks at SJVO2, and then factors in lactate and SCVO2 and a bunch of things, and then they decide to transfuse. I don't know how practical it is on a daily basis, but certainly if you have evidence of brain at risk, if you have evidence that the brain oxygen is low or SCVO2 is low, I think it would be an additional point to transfuse, right? So I think if you have those monitors in place, if you have microdialysis, if you have all of these things, you should combine that data to make the decision.
Thank you. There was one another point that I want to mention. I mean, I don't know. I mean, Dr. Prashant is there, and I thought Dr. Yash Javeri joined as well, and some of the seniors are there as well. I don't know what their practice is, but certainly what I practice is I use the crash TBI outcome prediction model. I don't use the impact TBI because crash they included Indian patients, and you can certainly select India as the region to get an outcome model by putting in the patient parameters. But the first trial utilized used the impact TBI. I mean that just a minor point, but when it comes to generalizability of the trial, that needs to be the results that needs to be considered. There's one more. Dr. Babu has put in his take on HeMotion trial. Shall I read it out? Yeah, which is HeMotion trial, more robust TBI patients with anemia, a restrictive transfusion strategy is not associated with worse neurological outcomes, mortality, or quality of life impacts at 6 months compared to a liberal transfusion strategy of 10 gram per deciliter. This supports the adoption of restrictive transfusion practices in TBI, aligning with general ICU guidelines to minimize transfusion-related risks. And this is more of a comment from him, and he wants us to discuss.
Sure. I'm not sure when Dr. Babu joined, at what point, but we sort of went over some of this. To answer the point, I guess, is that if you read the abstract or the summary, what Dr. Babu says is true, but the result of HeMotion is actually more nuanced, I think. Liberal did better in every group. They did better in terms of the final outcome. They did better in terms of the scores, the FIM score, the QOL, across a range of outcomes, although it didn't meet statistical significance. So I sort of spoke a little bit about clinical versus statistical significance. I also pooled the data from HeMotion with the TBI patients of TRAIN. To me, the totality of evidence actually suggests the opposite of what Dr. Babu has put, which is that liberal is actually doing better in TBI. Which does go against what we have conventionally been taught in the general critical care population. But I guess, these are subsets where we do expect differences, right? The ACS patient, the brain injured patient. So my view is liberal is better, but happy to be disagreed with.
We have at least, if it's just a single trial, then, it's going to be a little, maybe we need to wait for more evidence, etc. But yeah, 2 trials and enough TBI patients in those 2 trials. Agreed. The second trial was, they needed to change the number of patients several times, but still they managed to get the significance in the end. Any other questions? Any comments from Dr. Prashant?
Now, just the compliments to both of you to take us through this very wonderful journey of transfusion trigger. And if I share my experience and my practice, that when we were getting trained, we used to take 10 as the magical number for every patient, whether reaching a theater or the ICU. But over the years, looking at the trials, and also the data, what we have published and unpublished, we have come down to a trigger of 9 practically. So if my patient has 9, no one would shout for. But yes, if it is going below 9, yes, definitely it becomes a candidate. So that is what the practical practice has come with us. And I think what I'm concluding from Bharat is probably looking at a figure of 9 is, a middle path to the liberal and the restrictive one. And yes, definitely you can't wait till 7. Definitely for your patients, you can't wait till 7. One message is very clear that we can't wait for 7. But yes, you can adjust between 9, 8.5 or 9.5. That then the local factors play in, and you need to look for the patients and your setups local factor. And from there, you take a decision of at what percentile of 9 you will go for a infusion. Yeah.
Thank you. Any other questions? I don't see any more in the chat box. In that case, shall we conclude? Thank you, Dr. Bharat, for that wonderful session and talking us through not only the physiological data, but also talking us through the trials and also putting the trials together and giving us your thoughts on transfusion and TBI as well. And thanks to SNCC for coming up with this new idea of having neurocritical care journal clubs. So we'll be conducting journal clubs every month. It'll be like a different format every month. Although we are calling it journal club, this month it is evidence review. Next month it may be journal club. So it's going to be of different formats, and we are planning to conduct at least 6 to 7 this year. Thanks, Dr. Bharat, and thanks, Dr. Prashant, for joining us. Thanks to all the attendees, and thanks to all those that asked questions as well. Thank you.
Thank you, Dr. Deva. Thanks to SNCC. Thank you all so much. Good night.
Thank you. Good night.